Good afternoon, everyone. My name is Rebecca Szabo, and I'm the coordinator of the Women's Grand Rounds. Welcome. I'd like to acknowledge the traditional custodians of the land on which we stand, the Wurundjeri people of the Kulin Nation. We pay our respects to their elders past, present, and emerging, for they hold the memories, traditions, culture, and hopes of Aboriginals and Torres Strait Islanders and for Australia. Today would not have been possible without the ongoing commitment of the Women's to care for and advocate for all women. A special thank you to our Chair of the Board, Lynn Swinburne, and CEO, Dr. Sue Matthews. Thank you. Welcome to everyone in the room. And oh my, there are a lot of you. From the Women's, the Parkville Precinct, from all across Melbourne, including the other side of the Yarra, and those who've flown in from across Australia, including Tasmania, Sydney, Adelaide, and Perth. Thank you to those here representing colleges and organisations including ANZCA, ASIM, RACGP, ASA and NASOG, and the NH and MRC, and those from other fields, including Kirsten Hilton from the Victorian Equal Opportunity and Human Rights Commission. Clearly, this is not a regular grand round and would only have been possible with support from others. Thank you to the University of Melbourne, Department of Obstetrics and Gynaecology, and to FRANZCOG. And a special thank you to AMA Victoria and the team led by CEO Stephen Burrell and AMA Victoria President Associate Professor Julian Raitt for their support today and ongoing support around gender equity, diversity and inclusion. Why is gender equity important? Why are we here today to discuss it? It's important for our profession and the diverse patients and community that we care for. Despite equal graduate numbers for almost 20 years, we still do not have equity at leadership levels across clinical and academic medicine. This is true here in Australia, in the USA where Dara is from, and across the globe. So today, and ongoing, we're breaking down our traditional and geographical silos to discuss this together. The uncomfortable question I was asked most leading up to this round is, why are there two men on this panel? I can assure you of two things. One, this panel is by no means representative of every voice that should be heard on this issue, gender or otherwise. And two, every person on this panel is a feminist. Just as we all listen and collaborate for our patients, let's move forward together. And now I am very honoured to introduce Tracey Spicer, a strong advocate for equity, as there's no one more perfect to moderate today. Aside from being a multiple Walkley Award-winning author, journalist and broadcaster who has anchored national TV and radio programs, she is the national co-founder of Women in Media and Now Australia, and is passionate about gender issues. This year she was named the New South Wales Premier's Woman of the Year and has been awarded an Order of Australia. Welcome.
Rebecca, thank you so much for those powerful words in your introduction. I'd also like to acknowledge the traditional owners of the land upon which we meet today. And I'd also like to acknowledge that marginalised communities, particularly Indigenous women, experience inequality, discrimination, sexual harassment and indecent assault at rates exponential to the rest of the community. It is a great honour to be sitting here and moderating this panel, although I must admit I'm experiencing imposter syndrome as a humble journalist sitting here with these incredible people from the medical sector. I'm going to introduce them briefly and I'm going to give you their social media handles, so please engage in the conversation online as well. We'll probably talk for about 45 minutes, an hour, then we'll open it to questions. So have a think about what you want to ask, because this is an incredible brains trust we have here. Thank you all for coming along, because you are all such powerful leaders in the community and in the workplace as well. I'd like to start by introducing, all the way from the United States, Dr. Dara Kass. I'm admittedly fangirling right now. Assistant Professor Dara Kass works at Columbia University in New York and is the founder of FemInEM, an open access resource where they discuss, discover and affect the journey of women working in emergency medicine. She's also one of the founding members of Time's Up Healthcare, which launched in the US on the 1st of March, and her handle is @Dara Kass if you'd like to communicate with her. Next up, next to Dara, we have Professor David Storey. Professor Storey is the Foundation Chair of Anaesthesia at the University of Melbourne and Head of the Anaesthesia, Perioperative and Pain Medicine Unit. He's a Senior Investigator with the Clinical Trials Network of the Australian and New Zealand College of Anaesthetists and is Deputy Chair of the ANZCA Safety and Quality Committee. And next on our panel, we have Dr. Neela Janakiramanan. And her handle is @NeelaJan. Dr. Janakiramanan is a plastic and reconstructive surgeon who is the curator of Inspiring Doctors, which profiles women medical doctors. At the end of 2018, Neela worked on a grassroots campaign garnering the signatures of more than 600 doctors calling to urgently evacuate critically ill children and families from Nauru, and I thank you for that incredible life-saving work. Next we have Dr. Kirsten Connan. Her handle is @ConnanKF, and I do hope the F is for feminist. Dr. Connan is an obstetrician and gynaecologist who completed her Masters of Clinical Education at the University of Melbourne, researching gender equity in leadership in obstetrics and gynaecology in the Antipodes. The most influential years of her learning and training and specialist practice were proudly undertaken at Australia's largest maternity hospital at the Royal Women's. Yay! Next up, Dr. Skye Kinder, whose handle is @Skye Kinder. Dr. Kinder is currently appointed to the board of the Rural Doctors Association of Victoria and the Postgraduate Medical Council of Victoria. She was named 2014 Young Citizen of the Year for Bendigo, 2017 Junior Doctor of the Year for Victoria, and is the 2019 Young Australian of the Year for this state. Well done, Skye. Finally, right next to me, would you like to read it out?
Yeah, I'm just looking.
Is that correct? Dr. Simon Judkins. Simon's handle is @JudkinsSimon. Dr. Judkins is an emergency physician and Deputy Director ED at Austin Health. He's been a doctor for more than 20 years, working in emergency departments across Melbourne and regional Victoria, and is President of the Australasian College of Emergency Medicine and the Australian Medical Association. Before we get going on the questions and open it, sorry?
Not that last one, that was a typo.
That was a typo, that was incorrect.
Somebody else has got that role.
Somebody else has got that role. Darn. Are you sure there's something that you don't know? Before we open this discussion or open it to questions, I'd like to give a little bit of a warning. Even though we are talking about broader issues of equality, there can be some distressing material that comes up. If anything you find incredibly distressing, please feel free to leave the room, because these are very serious issues and it can bring up some episodes in the past for some people, I've found, while talking about all of these issues around the country. The first thing I want to talk about to frame the conversation, though, is what is gender equity versus gender equality? Dara.
So actually, when I give a lot of talks, I actually start out with this conversation always, because I think that common vernacular is really important. So there's a graphic, I don't know if anyone's ever seen it, of it's a family. So it's actually 3 different height members of a family. It's a tall, a medium, and a small person. And they're looking at a baseball game. Has anyone seen this? Yeah. Right. And so it starts out, they each get a box. There are 3 boxes to give to these 3 people. And so if you look at it equally, at equality, what does it mean? It means everyone gets 1 box. And when you see the people on the box, each on the same box, you realize that one person who needs no lift at all now is doubly tall in the fence that they're looking at the game. The person that is medium height gets 1 box, just actually clears the fence and can see the game. And the littlest person, which I think of as like my littlest child, you know, gets 1 box as well and can't see anything, right? That's equality. Everybody gets the same. Equity is you get what you need. right? So the littlest person looking at the game gets 2 boxes and now can clear the fence. The same middle person gets the 1 box, clears the fence. And the tall person who never needed a box in the first place doesn't get any boxes. And so when we think about equality versus equity, there are spaces for both, right? There are a lot of opportunities, and this is how I think about opportunities and resources. Those need to be equal. You need to have equal access to resources and opportunities. But equity has to be a reflection of what you need. And that is going to be different for lots of people. And so it's about knowing what the person needs to think about what would be equitable there.
Magnificently explained. Thank you, Dara. I was reading a report by the Bain consulting firm this morning about engaging more men in this conversation. And one of the reasons why some men don't want to engage is they don't see where the problem is. So I want to ask you 2 things. In medicine, why is this an issue for women in medicine? And why is this an issue for patients as well?
So I think that it's an issue for people in medicine, right? I think that immediately we frame this conversation not that it's only a women's issue. Unfortunately, it becomes a woman's burden a lot because that's what it is to be out of the position of privilege, right? It's that when something is not equitable, it's the person that is affected by it the most that winds up trying to solve the problem because they have to. So I think it's an issue for people in medicine, and we know for certain that having a better, diverse, and supported workforce in medicine is better for patients. In America, we have proven over and over again that having diverse teams for cardiac patients and surgical patients has proven better outcomes for mortality and morbidity. We've proven that women specifically have lower lower readmission rates for elderly patients. And all of our research, which proves that women are not inferior doctors, only exists to prove against the narrative and the presumption that they are. Right? So every time an article comes out showing that women are good enough, we like to say we'd like to not have more of those studies because really it's to get to the null that we all bring something important to patient care.
So what we're talking about is life-saving, isn't it?
It definitely is. It's patient-saving, it's life-saving, it's career-saving, and it's kind of crazy to not do. I mean, a lot of what when I get to in the middle of my throes of a lot of the talks I give, I just end up with, and that's crazy, right? Like the idea that we don't solve this is crazy because it makes sense for us as physicians, for our patients, for our employers, right? Who wants to train a workforce and then have half of it leave because they're either disengaged, disenfranchised, there isn't time or space for them to do what their work is. So it doesn't make any sense to not address this.
A lot of the problems at the heart of this are to do with bias. Neela, how would you characterise implicit bias?
So implicit bias is all of the biases that we all carry within ourselves all of the time, even the most enlightened people among us. And I'll tell a very, very short personal anecdote because I'm on this panel as this advocate for not having implicit bias. I had a friend in Perth call me and say, my anaesthetist's daughter lives in Melbourne, she's hurt her finger, can you see her? Here's her phone number, give her a call. And I called up this young woman and I said, oh, I got your number from my friend Sharon. I understand that your dad is her anaesthetist. And she said, no, my mum. My mum is her anaesthetist. And I was standing next to my female anaesthetist as a female surgeon as I said this. So this is my classic example of implicit bias. We all carry them, and when we exhibit them, it is not a moral judgment on our character that we have failed. It is simply an example of the fact that we are human. And I think this is why it's so important to understand implicit biases as implicit and structural rather than a personal moral failing. Because part of the reason we struggle to engage some people in these conversations, and particularly with no disrespect, some men in these conversations, is because defences and walls get put up because people see themselves as being fundamentally morally good. And most people are, but we can't just rely upon people's inherent character. We actually have to understand the structural barriers that exist and work to overcome them. And if I can take your equality-equity example a little bit further, equity is great, but there's still reasons why people don't get to that game at all, and there aren't enough boxes to go around, and we're struggling to make these boxes because there aren't resources within the system to make boxes. Whereas if you made the fence see-through, then no one would need boxes at all.
Right.
And if you then tear down the fence, then you have genuine participation where it isn't people watching elite players playing on a field, it's actually everyone playing a game together. And so this is what we need to get to eventually. We need to get to justice and participation and not just stop at equity.
It's a really fantastic analogy, and I promise I will get to the other panel members in a minute. But before I leave you, Neela, I want to drill down a bit more on that qualitative study in The Lancet about women working in surgery. What are some of the multifaceted challenges that are faced, and what can be done to stop women leaving the profession?
So that study by Ria Liang was an excellent Australian study looking at why women leave surgery. I am a surgeon and I love my college because they've done a lot of things the last couple of years to really address some of these issues. But before I answer this question, I just want to say this isn't a problem of just surgery. This is a problem across medicine, and the surgeons get a lot of flack for it because we are a specialty that is very heavily male dominated, and the women who go into it in order to survive are probably very strong and outspoken by character, and so therefore these things get called out. But I happen to know that there are women in this room who are physicians, who are obstetricians, who are, other specialties who have been driven outside of the specialties of their choosing for these exact same reasons. So some of the reasons that Ria found was that the workplace culture can be toxic towards people who are not a particular stereotype of person. And again, we talk a lot about women, but there are men who find it difficult to participate in these environments as well, because there is a particular kind of masculinity which is valorized, and not everyone ascribes to that. So we found that there were women who were being sexually harassed, there were women who were being sexually assaulted. We found that the workplace hours were toxic to a lot of people, particularly people with caring responsibilities, not just children. People have parents they have to care for, siblings they have to care for, spouses they have to care for. So, at the end of the day, we're not just doctors who go to work, we're humans with lives behind us. And so if we create these structures that make it very challenging for people to participate meaningfully in the workplace, then they will leave. And most importantly, what Ria found is that there were a lot more people who almost left. And one of the things that stopped them leaving was actually often luck. It was someone making a phone call. It was someone checking in to say, are you okay? Is there something we can do to help out? I recognise that perhaps the situation is a little bit difficult. And it often only takes one of those moments to stop someone from abandoning their specialty and actually participating. So these are things that every single person in this room can do. You don't have to write articles and sit on panels and do all of this sort of stuff. Everyone can reach out to a colleague and say, are you okay? How can we make the system a little bit different here in this unit, in this workplace?
Yeah, that's really powerful. Some of the anecdotes in that article reminded me of the media culture for women in the past 30 years, actually. And what we found in the media, and I'm interested to see whether this is replicated in medicine, is it tougher in rural and regional areas, Skye?
I think it's an interesting question because, I certainly don't speak for all of the regional and rural communities and people that participate in those communities, but from my experience, I've actually found that, I suppose to frame it, in regional and rural and remote settings, you often have to be quite creative. You're often chronically under-resourced and you need to inherently think outside of the box. And I think sometimes what we see in regional and rural health is outcomes that are actually quite revolutionary in many ways. And for me, one of the things that I feel that I have seen is quite a large participation of women in leadership positions. And I think that is quite revolutionary because it's a culture of needing people to be part of the profession and needing to accept everything that everyone brings to the table and to make the best out of the different skills that the different people have at that table. So, for example, for me, the Rural Doctors Association of Victoria board, 2/3 are women. The president of the Rural Doctors Association of Victoria is a woman. The CEO of the Rural Doctors Association of Australia is a woman. The CMO of the hospital I interned at in regional Victoria was a woman. The director of intern training was a woman, so on and so forth. So through rural health, I actually feel that I've had a great opportunity to see a lot of female role models.
That is incredibly encouraging. As a woman of your generation, have you seen a massive shift? Are you optimistic when you talk to, say, medical students?
I think that this is actually quite a hard question because, of course, I only have my lived experiences of what's happening right now, and what was happening 20 or 30 years ago. It sort of doesn't really have a bearing on whether or not I think the things that are happening now are okay or good enough. And so for me, do I think that there has been progress? Probably. But do I think that things are good enough? Probably not.
Kirsten, what could be done at a college level?
Yeah, that's a great question. So some of you might know that 2 years ago I surveyed all across Australia and New Zealand, asking both trainees and consultants for their views on issues around gender equity and gender bias and desire for leadership, and the barriers that both our trainees and our consultants felt that they had, both in terms of past experience and also in terms of hope. And I think there are lots of things, and I don't think it's unique to just the craft group of obstetrics and gynaecology, and nor do I think it's unique to just obstetrics and gynaecology in Australia and New Zealand. I think the issues that we feel within ONG are all across craft groups and are all across waters as well. In fact, the US has the largest publications around looking at both the barriers to female leadership within the ONG craft group, as well as the potential solutions. Some of those solutions will be really simple ones, like putting in breastfeeding rooms, because we know now that 83% of trainees in ONG in Australia and New Zealand are female. The average age of entry into ONG in FRANZCOG, our college, is 30.5 years. The average age of having your first baby in Australia is 30.5 years. We know on average 77% of women across Australia will have at least one, if not two babies. 1.81 babies, if you can have such a thing, is the current statistic. And so for at least our specialty, we know that the time that you're going into your training program is the time that you're likely to have children. We know that the WHO encourages 6 months of exclusive breastfeeding. That's not always possible, but we certainly want to encourage it. But we know that the average length of maternity leave for trainees around Australia and ONG is less than, on average, 3 months. And so how do we support those processes? We need to then put in some institutional options like breastfeeding rooms in hospitals. So some of these solutions are really simple. Others are setting up really designated and intentional part-time training opportunities. So we know that the college certainly supports the notion of part-time and flexible training, but colleges don't get to mandate what happened in institutions, and what we need is institutions and colleges to work together to actually make those processes be present every day. So part-time training programs, I know that RACS has one that's based in South Australia, which has had an excellent outcome over the last, I think, 13 years now, for quite some time. And there are no places in Australia where we do that. Formalised mentoring programs, whether that's with a female or a male mentor, certainly have been well and truly proven to be good solutions overseas. So they're just some of the really simple strategies, not unique to ONG, not unique to Australia and New Zealand, not unique to the women's, but there's a paucity of it playing out in the workplace.
Dara?
Well, so I just want to put it into context, obviously, everyone, so my eyes go all the way behind my head at 3 months of leave, which would be remarkable. We have none. That's fine. So that's not even the interesting part. So one of the things you said, which was actually incredible, it has to do with the timing of careers of physicians, specifically women, but all new parents at the same time that they're developing their career and they're also having their children. So we did a very small study recently in America looking at our largest colleges, including our obstetric college and surgery, neurology, dermatology, emergency medicine, in conferences, the largest conferences, to see if they had childcare and lactation support, figuring my theory was that if you had better childcare, you'd have more women at the conference, and that would be good. You can't track that, actually, because there are no demographics of the participants at conferences. What we did find, which was interesting, was that 2 of our colleges, or our specialties, actually not just didn't have childcare at their conference, but explicitly banned children from the entire conference, including the conference hall, the exhibit hall, the whole 9 yards. In fact, one woman in radiation oncology had brought her baby because her childcare that she had provided for herself had gotten sick, and she was breastfeeding her 6-week-old baby, went to present her poster, and was promptly told by security she couldn't go in. And so it's remarkable, just to give a little context, that she went and said, I'm the doctor presenting my poster. They said, no, you have a baby. Leave the baby outside, you can go in. What are you going to do, right? So it's crazy. So I bring it into the college level, and actually everybody here is a champion, is those are really easy things to do, is to say, we want to support all parents, because what better way to empower young fathers or non-birth parents to have their children at the conference to just provide those resources. But the effects of apathy are real, because what actually happens is nobody thinks about it, and then a woman comes with her baby to present her research that she's worked hard to get accepted and is turned away at the door. So I just want to put some very lighthearted, I guess, context into what you're talking about, which was a really long list of incredible suggestions, actually.
It's so important. I was able to remain at Channel 10 at a time when usually if you had a baby you were sacked, because I was able to breastfeed my son in the hair and makeup department. To this day he becomes ravenous when he hears the sound of a blow dryer. Some kind of Pavlovian effect there. Kirsten, you mentioned a lot of terrific initiatives. What about things like targets and quotas?
Yeah, look, some of you in the audience will know I'm a big believer in quotas. I think we've seen its value within politics, within Australia and certainly overseas. I know recently The Age published the data that's coming out of India in relationship to not just representation, but also the flow-on effect that that's having in relationship to legislative change around women's healthcare and actually improving healthcare outcomes. I have presented to FRANZCOG, my college, and I think other colleges are beginning to pick up on that conversation as well, the importance of being really intentional. So we recognise in obstetrics and gynaecology we now have 83% of trainees female. We have just crossed the threshold now across the board in terms of specialist representation, with 50% this year and 64% overall. Often people have waited for the pipeline, and there is no doubt that the pipeline will play a small role, certainly within our specialty, over time. But do we want to keep waiting for that to happen? Because certainly for obstetrics and gynaecology, we had 14% female representation on our board in the last council timeframe. We had the same representation in the previous council timeframe. We've just lengthened our council timeframe from a 2 to 3 year board, and we have exactly the same female representation again. So despite the pipeline, we're not seeing a shift in those top level leadership roles. So quotas are one of a number of intentional tools to be transparent, recognise the problem, state the problem, and do something about it to change it now, so that the people who are following behind you can then work towards taking down that solution and have it happen organically, because people have recognised the importance of opening their lens, looking for diversity, recognising implicit bias, looking into places that haven't looked for beforehand, and providing solutions for women to be able to be platformed. Because as Dara's alluded to, we know that amongst the cohort here, there are just as many equally valuable people in leadership, irrespective of gender, irrespective of ethnicity, irrespective of age, and that's something that I think we need to work towards.
Simon, we know from this Bain Consulting report that the vast majority of men are into gender equality, are positive about the movement. But how do we engage people and organisations who aren't passionate about it?
I think from the medical field, it was interesting. We were having this similar sort of conversation yesterday around, looking after clinician and trainee wellbeing. And I think, going back to what Dara was saying, this is all about the ability to deliver care for our patients. And we know that by having a diverse clinician group, for example in emergency medicine, having a team that represents diversity not only in gender but also obviously in the demographics of the population you're looking after, the patients who are turning up to your emergency department will inevitably deliver better care because it's also culturally appropriate as well. So I think we need to understand that as a diversity in our teams leads to better decision making, leads to better team coherence, and obviously the end result of all of that is really what we're all here for, is to deliver better care to our patients. So I think there we need to really understand that's ultimately our end goal. And again, in going back to that wellness space, exactly the same sort of conversation that we had yesterday was obviously inclusiveness and diversity. And diversity also impacts directly on physician wellness and well-being. That also impacts directly on patient care. I think if our end goal is to ensure that we're doing the best that we can do by our patients, then this is part of that end goal.
It's all upside. David, what can those in power do to change things?
I think that there are a number of things. The one is, and I want to reiterate what people have been saying, is when we consider the strategies of healthcare, we have the individual patient journey, we have public health, We have value, which is quality and cost. But the fourth bit is workforce welfare. That if you're not looking at all four, you're failing. And I think that is a very important strategic thing that we look at that. And then I think, you know, these issues of mentoring, flexibility, and inclusiveness. But I also was reflecting that it needs to pass all the way up the line. You know, we've got this problem in academia and in medicine. I was thinking about my own department. There are fantastic women who work in my department at the Austin Hospital, but there's only one in the leadership group. And you ask yourself, why is this? And I think the principles we're talking about aren't passed on to the leadership group. Similarly, in academia, there's far more women in the more junior academic ranks and very few in the senior. And I think because the expectations and the requirements people need to move forward, you know, the sort of things we're offering that the emerging people should also be applied to the leadership. So those abilities for flexibility, those components of inclusiveness and mentoring are important across the board. And I think that will help, because that really big jump from, you know, from out in an academic setting, from a senior lecturer to an associate professor and then a professor, how do we help particularly women make that jump? And I think is to maintain the things that have helped them get to the senior lecturer level into the leadership levels as well.
David, are there any initiatives at the moment beyond mentoring, for example, sponsoring instead?
Specific sponsoring, our faculty, the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne here has specific programs to encourage women. I think it's very important that I was on the council of NHMRC. NHMRC has programs specifically to try and award grants to women. So in academia or in research, the grant is the fundamental thing. That's how you continue your progress. And so there is active encouragement within NHMRC to fund women and their research. You know, the results of the grants were always reported in terms of the women who were successful. And often was, you know, a bit like others have said, you know, we're not doing as well as we really should be, no matter what we do. So there is definitely the will, there is definitely components that are helping.
Dara, what are some of the measures being instituted both culturally and practically in the United States in your sector that we can learn from here?
Really? Right now? Okay.
No pressure.
Okay, so I think that, you know, within medicine and emergency medicine, I actually think that in America, emergency medicine is actually one of the more progressive specialties in this space. And a lot of it has to do with the fact that we're a team-based approach in medicine, and we never really graduate from the intern level on any level in our medicine, right? So I think that knowledge that the workforce has to be accommodating to everybody, and that investing in a workforce and then watching them leave is in nobody's best interest, right? So I think that we look at things like workplace flexibility, we look at things like salary equity. I mean, one of the biggest things that I think is international when it looks at the inequity of you know, women versus men based on gender, and obviously, you know, in America, we can't even look at race as a factor for salary inequity because the N is so small that it actually de-anonymizes any of our studies, which is extraordinary, right? We know that we have 25% of our population is considered black or brown, but if you look at physicians, it's 8% and 5% in emergency medicine. Wow. So we can't do salary studies. But when we look at the raw data, we know that it is extraordinary, the salary disparity between both, you know, if you could look at a Latin female versus a white female versus a man, a white man or a black man, the salary disparities are extraordinary. So measures that we think about are things like salary transparency, right? And a lot of the other things that we look at are kind of what I call second order investigations. So when we think about salary, a lot of the answer is always, well, I get paid the same per hour, or I get the same per delivery, or I get paid, you know, it's not gendered. Nobody pays me different. The baby gets delivered, right? Nobody cares if I'm a male or a female delivering the baby, right? Well, if you look at the referrals to the physician based on their gender, and maybe you get referred all the babies that you can deliver, but you're getting referred 25% less patients. Or you're getting the complicated patients. You're getting the patients that are high risk, even though you're not necessarily a high risk doctor, because you're better at handling the social emotional complexities of that patient. In emergency medicine, we see that a lot. I may get the first trimester loss patients, whereas a male colleague may get the really complicated orthopedics patients, right? Because the nurse thinks I'm better at the emotional, complex patient, but Simon call you out as an emergency medicine doctor on this panel.
That's what I'm here for.
He might get all the hips, right? He gets all the hip dislocations, which pay better in our system than the first trimester pregnancy loss, which really doesn't have a lot of procedural intervention. So I think that the measures we're looking at within our system are the whys of why the inequities exist, because that superficial level of I don't get paid less just because I'm female or male, I mean, sure, I'll take that, but then we look at the levels of what contributes to where the metrics come in. We have a patient satisfaction score, right? That is entirely influenced by bias. Yet it's also how we get paid. And so these are the things that we think about in our world, which I don't know how many of them are pervasive here.
Well, I've seen people nodding their heads off to the point their heads are about to drop off, right?
Like
so
I said,
let's
it's
drill
crazy.
down. Yeah, I'd say it's resonating. Let's drill down a bit here. First from Neela, and then Kirsten, and then Simon, the three big nodders on the panel.
Absolutely. So, there is absolutely a gender pay gap in Australia. For the same reasons as Dara has explained, it's very hard to work out why that is. If we talk about junior doctors, we are on an award wage. All interns get paid the same per hour, all residents get paid the same per hour. It's an incremental wage, and yet there is a pay gap. And people always say to me, why does that exist? And to be honest, you only have to be a woman to understand why that exists. Female interns, female residents working in our hospitals are not encouraged to claim their overtime. They are in fact actively discouraged from claiming their overtime. We know anecdotally that when women do claim their overtime, hospital administration is less likely to pay it than they are for male residents. When heads of unit are asked to sign off on overtime, we know that female residents, registrars are told that they probably didn't need to be there, and they were probably just there to have a bit of a chat with patients, and maybe they were just being a little bit inefficient, and so therefore, it's kind of on them. Whereas when the male interns, residents, registrars do overtime, well, of course they wouldn't be there. They have football games to watch, unless they were genuinely doing clinical work. And so even from that very, very early stage, we start to see that there is a gender pay gap. Then people get streamed. There are specialties such as surgery, procedural specialties, which get paid more. And if you make those specialties toxic towards women, then they choose the specialties that have fewer hours, that have less overtime. And so they get streamed into completely different specialties where there are different rates of pay. And then when you get to the consultant level, you again have these referral pattern differences. Whether you're looking at GP specialists or whether you're looking at other kinds of specialists, women get referred complex patients that take a long time. And our Medicare rebate system, it's the flag fall, which is where the pay is for a consult. So you don't get paid double for a half-hour consult as you do for a 15-minute consult. And in fact, for general practitioners, it's 20 minutes or less. And so if you've got a bunch of GPs doing 10-minute consults, seeing 6 patients an hour, they're getting paid a lot more than GPs who are seeing 4 patients an hour at 15-minute consults. And in fact, there was a huge hullabaloo only last year about a clinic which very unfortunately made a poster which said female GPs, $90 and male GPs, $65. But if you actually looked at it overall, the female GPs were making 50% less than the male GPs because all the male GPs in that clinic were doing 10-minute consultations and all the female GPs in that clinic were doing 15-minute consultations. And I actually wrote an article on behalf of those GPs, and if you actually dig further into it, those GPs were bulk billing an incredibly larger proportion of patients than the male GPs because as female doctors, patients share their financial stories with us. They feel comfortable sharing, all of the psychosocial stuff that is going on. And at the end of the consultation, they also then feel comfortable asking us for a discount, and we feel terrible. And so, in my own private practice, my secretaries have removed my right to bulk bill patients. They say, it's up to us. You're terrible at this. You're not going to ever turn a profit. So the why is the difficult part, but in this country, if I may be blunt, we are still struggling to get past convincing people that this gender pay gap exists at all. We're not getting to the why. So what I really hope to get out of this is to say it absolutely exists, and it's not because women work less or women work less hard or because we're faffing around. It's because there are all of these structural issues.
These are deep structural issues, and I'd love to hear from you, Kirsten and Simon, in a moment, but I'd just like to broaden this out because I believe this is across all industries. In the media, for example, traditionally, men have done the political reporting and the finance reporting, and they've been very highly masculinised areas. They're the roles that end up going into leadership positions in the executive of media organisations. Women have traditionally done things like health reporting and social justice reporting because we are seen as being more emotional and softer. And they're not the roles that end up being executive positions. So there are clear parallels in all industries to this. Kirsten?
I was just going to pick up on two things that Dara had mentioned. So ONG's got a few little uniquenesses to it in that, different to maybe many other specialties, and some of you on the panel might want to reflect and think about what works in your craft groups. In ONG, actually, as a female consultant coming out, the data clearly shows, in fact, that we have an advantage. So if I set up my practice as a female specialist in private practice, I am 3 times more likely to close my book sooner than if I'm a male consultant. And that's a real concern, I think, because the studies clearly show that except for a very small cohort of consumers who are looking for a female when they're teenagers or in their early 20s, specific to gynaecology as opposed to obstetrics, that actually what consumers are looking for are the personality attributes that their clinician holds, not actually anything to do with their gender. So that's quite unique to ONG. The second thing is in relationship to males training within obstetrics and gynaecology, and I heard at the most recent ASM in Adelaide this conversation that was unfolding amongst a group of registrars saying how they were worried that they're a smaller cohort, the males who are coming through, that they're increasingly being excluded from training opportunities within institutions because there's more and more bias from those training institutions to support the women because they feel that consumers are demanding more female practitioners in that space. Actually, that's not what the evidence shows at all. And so their concern was, well, now that we know we're a female, we've got male colleagues, are they going to have the same skill sets as we do? So this issue, although clearly in some areas has a strong bias against females, in some other areas, in fact, has a really strong and evolving bias against our male colleagues. And I think that's really concerning.
Fascinating. Simon?
In emergency medicine, I think, yeah, no doubt there is a pay gap really related to a number of different issues. I mean, we're salaried, so most of us who work in the public hospital system are salaried. But I think, and I'm watching, there's a row about 6 rows back there of all my colleagues who are looking at me and they're going to give me messages about whether I'm saying the right and wrong things. But a lot of it is due to, I think, is there is certainly some discriminatory practices out there when it comes to employment opportunities, and we hear around about expressions that we'd prefer to offer the male FACEMs, the permanent positions, because we know that you're not going to have to go on maternity leave, for example, and female FACEMs tend to get the part-time roles or the 0-hour contracts because of the concerns that their organisation may have about that. But then longer term, it's about career opportunities and career progression and development. And again, I think that's going back to the leadership conversations and who's in the leadership roles. The directors of emergency medical departments around the country are predominantly male. And I think that is because it's seen that there's that long-term commitment. We'll promote the male, we'll give them the opportunities, we'll give them the leadership opportunities, and I think that's clearly clearly to the detriment of our female FACEMs. We need to really do a lot more work in providing opportunities and really bolstering their leadership opportunities, because we know, again, in the long term for patient care and outcomes for the well-being of our department, that's a really important thing to do. So there clearly is still an incredible amount of bias and a lot of discrimination in employment practices.
You've touched on something I'd like to throw to the whole panel. How do we advocate effectively for shared parental leave within our organisations? We know it works tremendously well in Scandinavia. There have been examples for decades. How do we do it here?
I love anecdotes because they speak to the culture, I suppose. A couple of years ago, I advocated for a male registrar whose wife was having a baby. She was having a caesarean. There had been a few obstetric complications, and he was told by certain senior people that there was no need for a man to have time off while his wife was having a caesarean section because she would be in hospital and she would be taken care of. And why couldn't he come and do on-call the weekend after she had the baby? And this is one of the issues. I think there is still a perception that men don't have an active role to play in parenting. And a lot of that is coming from what our leadership groups look like. You know, in Melbourne, there is a public hospital which has more heads of unit named Peter than women. And if you add, I'm sorry, the Davids and the Johns, it's about triple. So and a lot of these, so in generations past, you know, medicine was constructed as a specialty where long hours were demanded, where spouses often gave up their own careers to raise family and children. And so when you have leadership groups which are predominantly a certain generation, and those leadership positions are held for decades, you know, there are people who are still heads of unit in Melbourne that were the head of unit when I was a medical student. And I've now been a consultant for over 5 years. So when these positions don't change, when they don't rotate, these archaic ideologies get embedded, and it's all part of the fact that we are the industry that still uses fax machines and pages. You know, we're stuck 20 years ago and we're not moving on. And so, and there's this perception that in order to provide continuity of care, we can't hand over to other people. So we must be there all the time, and part-time positions won't work. And even though there's a huge plethora of evidence that part-time positions do work and handover does work, and giving men time off to bond with their families is actually really important. And given the number of families that are dual medical families, if you give the men time off, then you're actually supporting the women to support their careers as well, and you end up with a more diverse workforce. And so I actually don't think it's difficult to achieve this. I think we have enough structures in our public hospitals to cover each other. I think there are, certainly with the tsunami of medical students that have come out in the last decade, we have a huge workforce. We just have to decide that this is something that's important and we're going to do it.
Dara and then Kirsten.
So in our country, we have no leave, right? So we'll put that on the table, right? We have no leave. We have basic job protection if you're lucky, and that's actually for less than half our population. Having that said, parental leave, maternity and paternity leave, or any parental leave, is actually an extraordinary thing in America, you know, writ large. Having studied paternity leave specifically, supporting paternity leave is the best way to support maternity leave across the board, okay? The other part of it is champions of change. So Australia actually in 2012 had a whole commission, I'm sure you guys know this, right? The male champions of change, in the attempt to actually take the largest non-medical organizations, right? The 25 largest organizations, and increase the population of women in leadership. It was a remarkable endeavor that I talk about all the time as, you know, the Holy Grail. Anyway, I don't know how Holy Grail it was, but it was exciting. So having that said, the idea that male champions of change are critical to any actual meaningful change structurally, and that if men in power take paternity leave, the men beneath them will take half as much as they take. So if you look at like Silicon Valley in America, like these unlimited leaves we have, so in Netflix, you can take as much time as you want, or Facebook, or whatever it is. What they found was that even though it's unlimited, if the policy was take recommended 3 months or 4 months, then if Mark Zuckerberg took 4 months, then the people beneath him took 2, right? And so what was interesting was if he is nickel and diming or taking down his paternity leave, then it encourages the people who work beneath him to take even less. So back to the shared leave, we know that you have to be home for greater than 3 weeks as a new father to actually meaningfully bond with your baby enough to actually change your parenting structure down the road. So we know that men have to take at least 3 weeks. We know that they won't because the pay gap effects of parental leave are real, and if you don't have to take them, you won't. So what does it mean? It means that the men in the room, the few and far between you are, if you have the opportunity to take parental leave yourself, please do it. And if you don't want to do it for your baby or your partner, do it for
everyone else.
Do it for the system behind you. Do it for the man who works as the vice chair of your department or the new attending that's coming through, knowing that he looks to you as an example and that his leave actually supports the registrar, the consultant, or the person that's next to him, in that same peer level. Because it is about men actually being advocates for humanity in healthcare and about their place in their parenting and in their families. That actually is the most important investment, I think, in this conversation. Because if we don't empower men to reframe their own narrative, we're never going to get to meaningful success.
Terrific advice, Kirsten.
I was just going to say, one of the things that you've already alluded to was just the language that you chose to raise this issue. I think is really important in relationship to calling it parenting leave as opposed to maternity or parental leave. That's one of the first things that I think we all need to be mindful of, and at times I've certainly been at fault of that. I just wanted to talk about one particular example, and I saw that this particular couple were in the audience. I was really privileged to train at the Royal Women's Hospital, but I was also really privileged to be a couple of years below an obstetric couple who both took leave. So the woman of the relationship took leave and the man of the relationship took leave as well at different times and shared that parental leave responsibility. And it was such a great example for me to grow up in an institution, whether it was by the institution or by those individuals, to demonstrate the importance of co-parenting. Because the reality is, for those of us that are privileged enough to be parents, whatever that might look like, it always and should be a co-parental responsibility. And I just wanted to say thanks to them. And I think they changed the culture that we had in the women's in relationship to what that looked like. I think Anthony's now left, but he is now the head of the labour ward. And I think that's valuable and invaluable that was his journey to then not just foster what was important for his family life, but also for the generations of men and women that followed, that's the norm. And actually that's okay. In fact, that's great, and we should celebrate that.
Terrific role modelling. I'm going to open it for questions in 5 minutes, but before I do that, I want to ask a question of both David and Skye. David, first of all, what can we do, regardless of gender, if we see bias, discrimination or harassment?
I think the first thing is to call it out. I mean, I'd be the first to say I know at times I've been a coward in these situations when I reflect back on it. And I think part of it is just to promote the culture, just the ongoing everyday components. I wanted to give 2 academic examples and I must say I was very interested in the idea of the implicit bias, because the reason I know about these things is because I heard women speak about them. So one is what's called the all-male panel. And there's actually a website you can send a photograph of an all-male panel and you get a big David Hasselhoff. And I had to go from, is there a woman on the panel? Is there a woman on the panel? And I now just see it. So I've gone from my think slow to my think fast. And so, colleagues will say, oh, here's the list for this particular panel. Actually, there's a woman on that. So, and I think that's important. The other one was actually Dr. Julia Baird, mentioned about women and their titles. And I wasn't aware of this. And she said, and I actually rang one of my colleagues who's a professor of biostatistics, and I said, Julie, is this really going on? Even when you're a professor, she said, yep. And so I think another everyday component is to always introduce all colleagues, so this goes back to the whole point of everyone, in the same way. That you say, this is, Professor Julie Simpson, or this is Professor Michael Bloggs, but that's still on my think slow. I've got to move over to the think fast. But I mean, like today, our college president's sitting in the front row, and I'm pleased about it. It's one of the things we're going to bring up at our college ASM committee. I think the sort of thing the college can do is just to say our guidelines will make it, to my point, mandatory that at some point in introduction, all chairs will use people's complete titles. And I think hospitals should be the same. Whenever you have a grand rounds, the professor should get up and introduce the juniors by their titles, both men and women, because I suspect even at that level, it's probably the subtle, we've got Dr. such and such, and here's Neela. And I would be 95% confident, 99%, 100% confident that that's the case.
It's been proven.
Yeah.
You guys know that, right? It was proven in a study that just showed if men introduced, so men who introduced female colleagues, right? The dyad of male introducing men or female introducing females or females introducing men. The long and short of it is women who introduced other women, 95% of the time they used the honorific. Men who introduced women, it was 46% of the time.
Yeah.
So it was a huge gap. Men generally were much more casual and women were generally much more formal, but that 40% gap between men introducing women versus women introducing men is actually been proven out.
Yeah, so I mean, it should become 100%. So you treat everyone exactly the same, and I think that's what helps a lot of things. And because one of the things that struck me about the reading that Beck sent us was this idea that you want to help women, but you don't want sort of, oh, you're getting this because you're a woman. That everyone should be getting this. And I think that's that to me, was an important new thought in the way to think about this. is that you try and make it the same for everyone, so you're treating everyone the same.
You've brought up such important points there, David, and I want to give you a little bit of a break before we go to Skye, because I want to reframe something. You're not a coward for not calling out those things. And the way I want to reframe it is by recommending to everyone in the room to follow Dr. Michael Flood on Twitter. He's an academic at a Queensland university, and he talks about the code of mateship, that it's very hard for men in a workplace setting or a social setting to call this stuff out because there is fear of backlash. In the same way as there's fear of backlash for women calling this out, but this code of mateship, particularly in a place like Australia, very masculine kind of culture. So I would encourage every man in the room to be a fantastic active bystander and a wonderful ally, but I also acknowledge that it is difficult to call this stuff out. So thank you for bringing that up. Skye?
I suppose from my perspective as a trainee, it always comes back to that hierarchy system and oftentimes, and I know this has been discussed in a number of medical forums before, but oftentimes the burden of change is put on the trainees to call out the behaviour of their seniors, which is an impossible situation that you just cannot, in many situations, actually do. I know that I'm very fortunate at the department that I'm in where they don't call it a flat hierarchy. They actually almost don't like the term because it still has hierarchy in it, but they have a flat culture where the door is always open for the director of our department, and you will freely, his name is Peter, you wander past and you say, hey Peter, how you going? And one of the things I often say, just as a casual thing when people ask me how I'm going, I say, oh, no complaints, just as a sort of throwaway line. And one of the things that he says to me quite often is, but if you had a complaint, you could come and tell me about it. And it's those small things that actually make quite a big difference as a trainee, to feel empowered that this isn't actually my fight. It's everyone's fight, and it's about making sure that the right people can do the right things to support us.
I mean, I just want to re-emphasise that's an incredibly important point, because for us to expect our trainees to come and have the confidence to report any sort of bad behaviour, discrimination, bias, bullying, that's really, really difficult, a really, really difficult thing to do. And we find it difficult to do. Imagine what it's like for our trainees. So I think the onus is on us to lead by example and ensure that we're constantly in touch with our trainee docs and that we're there to support them.
Absolutely, because what we're talking about here at the heart of all of this is a power imbalance. I think it's a good time to open this for questions. We've got half an hour for questions, and please shoot your hand up to pick the brains of the incredibly qualified people. I'm going to take you down the front here and then you in the middle. Thank you.
Not our attitudes changes legislation. So how about all the colleges and the AMA start talking about this at a federal and political level, as well as all of the other issues. We have in Australia, in I think 2012 figures, we have OECD countries. I think we educate our women to a high level, one of the highest levels in the OECD, and yet our labour force participation is number 34. It's number 34. So my microphone's off. Is that right?
That is a fantastic question. Thoughts from the panel on the colleges, for example, using their power to call for nationally funded childcare?
Similarly to the conversation we had yesterday when we were talking about clinical doctors' welfare and wellness and well-being, I think as colleges and medical bodies, there are some fundamental things that we can agree on. And there doesn't seem to be much point that we're all trying to fight those fights by ourselves and try and institute that change in each organisation. I think we need to agree on some fundamental change that we can all sign off on, so that becomes the new standard. And so that's very applicable to things like maternity leave, to things like friendly rostering when somebody's coming back from maternity leave. How do you allow them rostering that suits them not necessarily has to suit the organisation. And I think there are some very basic things I think that we can all agree on that will make some significant change.
Thank you. Terrific question. There was one in the middle. Thank you.
We've talked a lot, first of all, thank you for being an amazing panel, it's been fantastic. We've talked a lot about doctors interacting with other doctors. I'm a medical student, and I don't know a single other female-identifying medical student who doesn't have a story about being harassed by a patient. What can we do as a system to protect female-identifying people in medicine from harassment by people who aren't their colleagues?
So we've been talking about this a lot recently, obviously, with the evolvement of Time's Up healthcare, right? This is actually a really big deal because when you think about harassment for anybody who's female identifying, but really anybody who is in and out of privilege, in healthcare specifically, we have a very interesting dynamic insofar as we go into a room as a woman physician and we come out, and then let's say there's something that happens with a patient, and let's say that he's powerful, a donor. In America, we had a very famous case of a huge donor at a major medical center who totally harassed his physician in a room, and she left, told her supervisor, and was told not to say anything because he had more money than the institution and would bankrupt them. Okay, so I think that there are so many complicating factors when we are, because of the fact that in healthcare our patients are vulnerable, we're supposed to be the care providers, we're supposed to be in charge of them, and then the dynamic is shifted, and again, as women, the power is entirely taken from you in that moment, and we have spent our entire careers building power, right? Creating a hierarchy by which our opinion matters, and how do you do that? And then if you take the idea that half the time somebody is not wearing clothes in our interactions, right? Which sounds crazy, but that is an introduction right there in that moment that makes a lot of people feel vulnerable, and they may act inappropriately, take advantage, and all that other stuff. So the answer to you, unfortunately, is there are no good, quick answers. What it means is our systems have to support our workforce in a very consistent way by which our trainees, our faculty, know how to be supportive, have reasonable reporting structures, have reasonable reactions if a patient does do something inappropriate, and context. Right? So is it a demented patient who actually does not know what he's doing? Or is it a patient who is exerting his power in that moment? Where is that going to happen? And what does it mean for the supervisors to support the trainee or any physician or any nurse? I mean, nurses are harassed exponentially more than physicians, actually. And it gets higher and higher the less privilege you have in your society. So if you're a woman of color, if you're an hourly worker in America, if you're somebody that's not a physician, if you're the cafeteria worker, it may happen as well. So there are all these other layers of privilege that we actually have as women physicians, that we have to actually be the champions of change in this structure versus the other women in healthcare that don't have nearly the same advantage that we do. So I'd say it's a very complicated issue, but it's one that we have to really look at systemically in order to support everybody across the board.
Does someone else want to weigh in on that one?
What I would say is that I'm not familiar with how medical students are structured in America, but here in Australia, certainly my experience of being a student and my experience of supervising students is that you are often alone, that you are nominally attached to units, particularly in the early clinical years where it's not necessarily one-on-one in a unit, and there is this expectation that around tutorials, lectures, whatnot, you will just go and see patients. You might ask a registrar, who's a good patient, who's a good heart to examine, blah, 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 and then you will just go and do it. And I think that one of the things that we could do for medical students is actually give you a better protective structure, give you genuine mentors, because we know that approaching the Dean of Medicine at your clinical school is a big step, and that students won't go to those higher levels. So perhaps, and this is just a thought bubble, not a formed policy, maybe by giving you guys a little bit more support and more contacts within the clinical system and people to go to if you have these sorts of issues, that might be a good start. The one thing I would say is our public hospitals are actually generally pretty good at chastising patients. There are actually very good structures in place for when a complaint is made, where patients are told to settle down or they will be evicted, and I've certainly seen that happen. So those structures exist. It's about linking you guys in with those protective structures.
More broadly, this is something we're looking at with a documentary we're doing for the ABC on Me Too, and I see a parallel with people who work in hospitality and are sexually harassed or assaulted by customers. 90%, 9 in 10 is the rate, according to the union. And a lot of it's about obviously boosting authorities like WorkSafe, but also reframing it culturally as a workplace health and safety issue. So certainly you can go to your superior, certainly you can go to HR, but you can also go to the work safety officer if this is happening, particularly on a regular basis with patients or with customers. So there's a whole conversation happening around that at the moment. Thank you for asking. I think there's a question in the middle here, thank you, and then we'll take those two in that row.
Thank you. Caroline Homer, I'm a midwife, probably the most unequal profession in the room, unashamedly. I wanted to ask about leadership though, because it seems to me we need a new way of thinking about leadership. And yes, we need from the grassroots up, but we also need from the top down. And the sort of traditional leadership models that I've seen in hospitals are very masculine, very tough, not very, can I hear your complaint kind of leadership. And I think it's been a week of seeing a different type of leadership with our colleagues across the ditch. And Jacinda Ardern showing a very unique, kind, engaged, loving way of doing leadership. And I just think we need to bottle some of that. Because if we had that in our hospitals, in our health systems, in our universities, it would look different. I feel it would look different, but I'm interested in how we get to that next stage.
Skye?
I would just like to, I suppose, reflect on what you've said, because it reminds me, as I mentioned earlier, I've had the great privilege of actually having a number of sort of strong female leaders that I've been able to model myself after. And when I was thinking about this panel and I suppose women in medicine, what I thought of was each of the women that have had a leadership role in my life, I've taken from them a small piece. I've seen them interact with a situation that was negative in their own way, and each of them very differently. And I've taken a little bit of that. And for me, when I think about my leadership style, I think of it as an amalgamation of all of the small pieces. And I feel like the more women in leadership roles we have, the more comprehensive an amalgamation of all of the pieces the young women have to draw from, the more tools we have in our toolkit to pick from. And that's been one of the most powerful things for me, I think. And when it comes to leadership positions, as a junior doctor, Tracey very kindly mentioned the two boards that I participate in. Both of those, I got a tap on the shoulder beforehand by someone in the organisation saying, I know that you're interested in this and I think you would be good and I think you should go for it. They weren't things that I felt out of the blue that I had the skill set to go and do. And even, one of the committees for one of the boards that I participate in, it's Finance and Risk Committee, which is something I have no experience in whatsoever. And I mentioned to the CEO, who participates on the board, who is female, that I might be interested in giving that a go. And the first thing is I felt comfortable mentioning it to her because I knew that she would understand where I was coming from as a woman. And she said, go for it. And in the meeting where you had to express your interest, I started to chicken out. And I saw her look at me from across the room and just stare at me and until I put my hand up to say that it was something that I wanted to do. And she, with no words, gave me the permission and the confidence to go for a leadership role that I quite frankly wouldn't have gone for without her.
I think, we reflected on the point before, directors of departments who have been in those roles as directors of departments for 20, 30 years aren't necessarily leaders. The way I think many people have got into the role of being directors of departments is because they've been working at the hospital for a very long period of time. They've done a fair bit of research. They're a good surgeon or a good emergency physician, and they're sort of there at the time when the other director steps down and they put their hand up and they go, we'll give you a go. But nobody ever actually asked them about their qualifications to actually be a leader of a department, and there's a very different thing. So I think we need to change really the job description of what a director of a department is. It is a leadership role where you're going to influence the culture, not only of your department, but of your whole organisation. That's very different to being a director. So I think we need to evolve those roles. We need to offer leadership training for people. I mean, clinicians, you know, in my experience, becoming a director of a department all of a sudden, because it was very much that sort of experience. And I suppose I'm a symptom of part of the system that we're talking about, that I'd never really had any hurdles to becoming a deputy director or a director of a department, because I was there all the time and I worked really hard. But being a leader is a very, very different thing, and we need to offer leadership training. We need to offer support for people coming to those roles, because they're incredibly pivotal about how an organisation is run and the culture of that organisation, and whether they're going to offer supports to people that need supports.
David?
I was just reflecting on what Simon was saying. I think this is potentially an opportunity to, particularly if we are going to advocate specifically for women to come into leadership roles, there are some university departments, chemistry I think being an example, where you only do 2 years as the head, and then you rotate out again and you go back to your research. One of the problems we have in medicine is this tradition, I think a particularly blokey tradition, that you become director, you're all powerful, and then you retire. And so rather than saying, because I'm such a big wig that I can't possibly go back to a different role. And I think if we had a much stronger culture of more frequent rotation of directors, particularly because if you think about it, you come up, you've got a director who's a collaborative person, not a pain in the arse, who is happy to rotate out of that position, go back to be a senior clinician in your department, who will continue to act as a mentor but is not the director. And so if you say, right, we're going to bring it down to even 3 years, and we have an emerging group, say 3 or 4 people, ideally at least half of whom are women, and you rotate them through. So the university is exactly the same. No one should be a king exactly for 20 years or even longer. I think that is a very important thing we need to stop doing. And I think one of the big advantages would be to be able to help women more rapidly come into leadership roles.
Terrific suggestion for structural change and reframing leadership. We have a question here. Oh, and one at the back. So one at the back and then there. Thank you.
Good afternoon. My name's Kirsten. I don't work in the health sector. I'm here though today because over the last 6 months I've received numerous complaints of the most serious kind from people who work in your profession. So I'm Victoria's Equal Opportunity and Human Rights Commissioner, and I wanted to thank the panel and thank all of you in this room for the discussion today. It sounds like there's great pockets of positive progress, but I also hear some of the most outrageous forms of abuse and harassment that are happening in your sector. And the complaints that I receive, people won't make a formal complaint because they don't trust in the processes that are there to support them, and they don't trust that if they do make a complaint, they won't be marred or stained or unable to progress or move through your profession. For the last 3 years, we've been working with Victoria Police on similar issues. And one of the things about that piece of work, which is long and deep and very complex, is that you don't make systemic change unless you have a very good understanding of all of the histories, languages, business rules, ways in which people come in, ways in which people move out. Until you understand those things and actually develop a radical and disruptive process for changing those, and that requires really deep and thoughtful work and an ability and an open and a want to be open to scrutiny. And it sounds like there's an interest for that in this room, and I would encourage you all to think about how you might make that happen, because there is momentum, there's tremendous interest in this at the moment, and if there's anything that we can do to support you, because there are a few people who have more important roles in our community, and you deserve your workplaces to be safe and inclusive and respectful.
Firstly, can I say thank you so much, Kirsten Hilton, for the transformative work you've done in the emergency services in Victoria. It has been incredible, and I know what tough work it has been for you and for your department as well. It's just incredible. Before we go to the next question, I'd like to get some feedback from some of the panel members on that. the idea of transformative, disruptive, deep-rooted change?
Yes. I mean, it's my brand. You know? It's true. It's like, because it's the kind of thing where if it's always been done that way, that's probably not the right way to do it anymore. But it is a problem. And all of these, look, medicine is a hierarchy and a patriarchy together at the same time. So the only way to fix it is to disrupt the patriarchy and the hierarchy with respect for the system, right? And that's really what it comes down to. So all of the reasons why patients are vulnerable and physicians are vulnerable is because of that deep-rooted patriarchy and hierarchy. We know that 85% of the people that bring EEOC complaints in any sector are punished for the complaint. They don't get retribution. So why would you ever bring a complaint if you are 85% most likely to see consequences to yourself? That's crazy. It's what I say all the time. So I agree with you, and I think that it's remarkable that you're here. I think it's remarkable that you're all here looking for meaningful change at a system level. I think that I am jealous, to say the least. But I think it's wonderful, and I think that it will happen. But it's going to take time.
I mean, I think changing the medical system is incredibly hard. And I just, on a slightly parallel, I remember talking to the South Australian Health Minister about transforming health. South Australia, and he said the biggest problem with transforming health was the embedded practices of the clinicians in that system. He didn't want to change anything.
Right.
And so, trying to change the system is a challenge. But I think, we need something disruptive.
And this is a terrific starting point. Yes, David, and then I'll take the question in the middle there.
Just a very quick point in how to change things is to find a friend, find 2 or 3 hospitals prepared to take it on as a pilot. So we work out what the bundle is, the so-called bundle of care, say 5 things we want to do, and you get a hospital that's got CEOs prepared to take it on, and I know that there are 2 female CEOs at least. There's not.
Are they in the room today?
One is here, but I was thinking the CEO of the hospital we're currently in is a woman, the CEO of the hospital I work in is a woman.
All the rest are called Peter.
But sorry, but I think that's the way to get it done. Find representative hospitals who will take part, who'll adopt the bundle and show it works.
I think we have a volunteer for the pilot program here. Next question, thank you. And then we'll take the one in the row, the same row, because you put up your hand before, and then we'll go down here. Thank you.
Kimberly Humphrey, I'm an emergency medicine physician from Adelaide. I'm also on the diversity and inclusion steering group for the College for Emergency Medicine with Simon and Claire here. And one of the things that we're doing is trying to get better gender equity on our governance structures in the college, including the board, which doesn't have any gender equity. And one of the comments that I've received, and I know others in our group have received from people, is that selection should be based on merit. And one of the things that comes into that, I think, into selection in general, is implicit bias. What I've read about training for implicit bias as being quite contradictory, and I was wondering if the panel has any insight into things we can do in terms of combating implicit bias.
I want to talk about merit, because we haven't actually talked about merit, so I'm really glad you brought it up. Merit, we had our Prime Minister on International Women's Day stand up and say, I'm all for women getting ahead as long as it doesn't come at the expense of men, which is an interesting concept, because what that basically says is that men fundamentally have merit, and so therefore some of these meritorious men are going to have to step aside for less meritorious women to get ahead. What it doesn't address is the fact that maybe some of the men in positions of power don't have merit, and maybe the way that we have chosen to define merit is a little bit not quite right. And I think there is no industry where that is more the case than in medicine. There was a Harvard Business Review article recently which looked at a study where they looked at how men lead and how women lead, and men tend to be very task-oriented in their leadership, whereas women tend to be more human-oriented in their leadership. And this is not biological, this is completely socially constructed, but that's how it plays out. And in medicine, in our units, we tend to see patients as problems. We see them as a heart to fix, a brain to fix, a hand to fix, whatever it is. And so the leaders that we have chosen are very task-oriented and very good at fixing a heart or a brain or a hand. That doesn't necessarily mean that they are good at treating every patient, every whole patient, because we're not hearts and hands, we're people attached to hearts and hands. And it also doesn't mean that they're necessarily very good at bringing together a collaborative group of people to run a unit well. So I think the first thing is we don't need more research. You know, as Dara and all of the American, you know, gender equity champions keep saying, we have plenty of research. We have research in medicine, we have research from pretty much every other industry on the planet as well, that if we have diversity, businesses perform better, they are more profitable, they provide better care. And so we need to look at what is truly meritorious when we go and select our leaders. And so, yes, we can do diversity and inclusion training, yes, we can educate people, yes, we can do all of those things, but it's already out there. And, you know, the College of Surgeons, after its, you know, expert advisory group, has, you know, quite comprehensive programs in operating with respect. 99% of surgeons have done that. We all work with surgeons. We know that 99% of them are not currently operating with respect. And so these courses, these programs in and of themselves aren't going to create change. We actually have to completely disrupt the system, completely, and this is where people from the highest levels of government have to step in. You know, it's great that we have the Equal Opportunity Commissioner today. Where is the Health Minister? She's the person paying for our public hospitals. She's the person overseeing how these hospitals are running. And if there are more Peters than women, then that hospital, by definition of any industry, is almost certainly less profitable and less efficient and less effective than it could be. So why are we not conditioning the funding of our public institutions on having diversity in the leadership groups?
Great points, Dara.
Okay, so it's awesome. Somebody asked me once if I was advocating for salary transparency and equity with a male colleague, would he be okay with it because he knew he would either have a raise delayed or he would actually make less money? And the answer is sometimes opportunity is a pie. And sometimes there are limited opportunities. Seats on a board of directors, chairman of hospitals, those are limited opportunities. And so when you have a position of privilege, like you were just saying, there are going to be people, generally men, generally white men, that are going to react badly to the idea that they're going to get less opportunities than they would by the current state of affairs. That's progress. Okay? And the truth is that we need to look at the entire system writ large and say, hey, we need to have more diverse teams. There will be less white men in charge because there are more room for people at the table and there are only so many chairs, right? And so why do we advocate for diversity in leadership? Well, we do it because historically, the biases that got people into leadership, like the meritocracy you're talking about, kept everybody else out. So affirmative action and quotas and all the things you were talking about before are only important to neutralize the biases we're up against. They're not supposed to change the narrative to give everybody else new advantages. They're literally just leveling the playing field. Mm-hmm. That same picture I talked about at the very beginning, there are other versions where it talks about reality. And reality is that one person starts out in a ditch. Okay? So it goes back to the board of directors. There should be quotas for boards of directors because the truth is, and there should, and the same thing is true for colleges, right? Because at the end of the day, the presumption that we as women physicians are somehow less qualified than our male colleagues by virtue of our gender is crazy, right? We've all gotten here at the same time. But we are institutionalized to believe that somehow the meritocracy says we're just not that good.
Meritocracy land should be next to fantasy land at Disneyland, in my opinion. If you could please pass the microphone along the row, that way we have time for 2 more brief questions, or has your question been answered? No worries. I'll take the question from down the front because you put up your hand earlier. Okay, brief question from here, brief question from there, and then we'll have to wrap up, I'm afraid.
Hi, hello. I was going to ask that, yes, we are obviously very clearly trying to fix a problem, but what energy can go into children or in primary schools or in education so that we actually try and prevent that for the future? And is there any research around, trying to, create this balance for better in our younger generation?
Anyone else want to?
Kirsten?
Taking over the...
Yeah, certainly coming out of the US, I think it's the American Academy of Medicine, which is the overarching body for medical schools. They're now running programs that are trying to acknowledge the presence of gender implicit bias and trying to change the conversations that medical students have. So there's lots of studies that show that from first year medical school, and it just gets worse as time goes on, that if you ask people to put their hand up to be a leader in a group activity, that as they go through each year of medical school, the number of females that are prepared to do that, it drops down further and further and further. And so having the conversation saying, actually, why did you do that? And what can we do to actually promote you to try and, at a very early level through their medical careers, acknowledge that gender bias exists, that we all have, as Carolyn was alluding to, that we all have an idea about what a leader looks like. We're now trying to change that in a transformational way, and Jacinta Ardern's doing that beautifully for us. And how can we support you in that process? So I think that conversation is really important, not at a college level, absolutely, but you're absolutely right, from how we enculture our children in society from the moment they're within our families, but also through our medical schools. And we obviously all won't have the capacity to do that apart from just everyday behaviour for other families, but we certainly as an organisation will have that capacity for our registrars, and as colleges we have that capacity for medical schools as well. And I think that there's a huge impetus for us to do that if we're going to be truly transformational in how we change the playing field for everyone.
Eloquently put. We have a question at the front, and then we'll have a brief one in the middle, and then unfortunately we're out of time. Pardon, more a comment? Great. Yep, fantastic.
Just a comment. As the CEO of the Women's, I wouldn't be here if I didn't firmly believe in this. I think what I want to do, though, is before everyone else leaves, thank you to the panel, but also to thank Beck for bringing this to the forefront, and to all of our sponsors. But I also want to talk about how proud I am of the Women's, because I hear about lots of things that go on, and we are not perfect, but we do have a culture that promotes women, that supports women, that talks about equity, not just equality. And I just want to make sure that everyone knows that before they leave, and students can come to my office if they need to say there's something that's going on that's not right. And the board is fully supportive at the Women's, so it's a really important topic for us, and I thank all of you for today.
Thank you to the Women's for what you're doing. Thank you very much.
Thank you for having my question. My name's Leah, I'm a final year medical student, and I'm involved in an organisation called MedFem, which we started to basically try and tear down that wall, or the fence that we were talking about. So my question for the panel today is, much like here, everyone who's come in has come because they have an interest and they recognise that this is an issue. My question is, how do we take this conversation outside of the echo chamber and outside of the people who we know agree with us?
Such a perfect question to finish on. And I'd really like a 30-second answer from each of you, starting with Simon and ending with Dara.
Well, I think at our level, at a college level, we can start to, because we reach across 200 hospitals, 300 hospitals across Australia, where we have emergency department trainees, emergency department physicians. So we can start to, I suppose, lead by example, set the tone of the conversations, ensure that we do promote our female FACEMs into leadership positions. And when we're really starting to really put that structure together, we need to really invest in ensuring that in many respects you can't be what you can't see, and so we need to do a lot of work to ensure that we actually enable all of our emergency physicians the opportunities to get to those leadership positions. But we really need to focus on, as I said, our upcoming leaders and ensure that they're going to step into those roles, so we just change the face of what emergency medicine looks like.
For me, I obviously shared that I have had taps on the shoulders to go for things, and I think at the junior level, one of the things that we are in control of is tapping our juniors on the shoulders and passing it forward and saying, I did this, you should give it a go, I'm going to support you to do it. Even today, Neela offered me a ride here. It's very, very intimidating, as a junior doctor to come and speak at a sort of grand round like this, and just the small taps on the shoulders that just say, we're here. We can all do that to pass it forward and take it from the slow thinking that David talked about to the fast thinking where we just do it all the time.
Two quick points. One, value your voice. So don't ever feel too small or too insignificant or too insecure to speak up. You'll need to find the right platform and the people that you trust to do that. And the second thing is to build a network. I thought networking was a really dirty word when I first became a doctor, and now I can see that it is absolutely invaluable that I have people that hold me up and I hold them up in turn, and exactly as Skye alluded to. And then we as a network build up other people behind us, and I think that's a great responsibility that we all carry.
What I wanted to say is that you're not alone. There are actually now enough people, and I really believe this in my heart, enough people who want to see change, who are well connected, who do have networks and rafts of otters to create change. And so if you find yourself in trouble, if you find that something is, you're not happy with it, reach out to someone in your organisation. Every single hospital in the state has someone who will advocate for you and who will take your cause and make it not your problem anymore, but will take it to the right people. So trust in that echo chamber, that we have influence on people who are not part of the echo chamber.
I think that there are the components we look at within medicine, but it's incredibly important that we, as medical people, ensure that the message is a community thing. That if you consider, particularly for those who are hospital-based, we have our nursing colleagues, the majority of whom are women, that the things we're looking for ourselves, we ensure that it's happening for them. Someone mentioned, that the woman who works in the cafeteria, that it's happening for her. And that I'm glad the AMA are here. Part of the community health component of this is to say this is something for across the community. Yes, medicine can lead in it, and yes, we have our own perhaps specific problems, but a lot of them apply to others as well. And so there's our local thing, but also the community-wide component.
I think that bringing back to your point about how do I empower other people to care about this, right? Well, you know what? This isn't actually about me, and it's not about them, right? It's about the system, it's about the patients, it's about the progress. I have no need for further lactation space anywhere I work. I am never having another child, right? I have surgically fixed that. But at the end of the day, I'm gonna make sure that there are appropriate spaces at every conference I go to, at every place I ever work, right? This isn't about me. And when you depersonalize it, and the last thing I'm gonna say, and I kind of was holding on to it for a second, is that the need to kind of aggregate wellness with equity is actually a thing that sticks in my craw. Because this isn't actually a wellness endeavor. There is a workforce burnout issue, and there is an issue around suicidality and depression and all kinds of other things when you come to the stressors of being a physician. But this is for some reason, gender equity is always parked on the wellness committee, and I don't understand that, because this is not about feeling good. This is about survival. Right? And this is about having a workforce that's empowered, and it's about saving patients, and it's about moving forward. And so if anybody else can help take this away from the wellness committee, that would be really helpful. And to depersonalize it, use the data, use the science, remind everybody that they're part of the solution, right? Because somewhere along their career, whether they realize it or not, whether it's the fact that they've been the breadwinner for their family their entire life and never for 5 minutes got a chance to realize that they might actually want to stay home for a few months, but they couldn't because their career was so disproportionately male that there was no way that they could ever stay home, right? So if you kind of go back to that level and depersonalize it on a system level, but actually remind everyone how they've been affected by this, regardless of their gender or race individually, it actually brings back a lot of people to feel like they can be part of this fight.
Some incredible wisdom there. Before we wrap up, I'd like you all to close your eyes for 5 seconds and visualise a strong leader. Okay, you can open your eyes. Who visualised?
Perfect timing.
The conversation was so hot it set off a fire alarm. I'm telling you, this is red hot. Who visualised a politician? Who visualised a business leader? Who visualised someone in your sector in healthcare? Who visualised a community leader? Who visualised themselves? Dara is right. Each and every one of you in the room is a leader. In your family, in your community, and in your workplace. What we've discussed over the last hour and a half, please use that to create a ripple effect for those around you. The great Martin Luther King Jr. said, "The arc of the moral universe is long, but it bends towards justice. And that's what we're seeing at the moment. Every person in this room can play a tremendously powerful part in this fight for justice. Thank you for coming along. Please thank our tremendous and stellar panel. And a huge thanks once again to Dr. Rebecca Szabo and the sponsors for bringing all this together.